Okay, good morning, everyone. Why don't we get started? Welcome back to our Grand Rounds series. We did have a week off, so I hope everyone's finally dug out of the snow. This morning, we have one of our very own local faculty, Dr. Matt Schlenker. I think everyone knows Matt. He has practices both at the Toronto Western, he operates at Kensington as well as Trillium. And in addition to his busy clinical practice, he is a prolific researcher. During residency, Matt completed a Master's of Science in Epidemiology from the Harvard T. Chan School of Public Health, and he's currently both a clinician at the aforementioned hospitals as well as a scientist at the Institute for Better Health, and does a lot of big data type research, both himself but also with the residents in our program. So it's our privilege to have Matt's glaucoma expertise, but also stats expertise as a faculty member in this department. Matt, I look forward to your talk this morning. Thank you for joining us for Grand Rounds.
Great. Well, thank you, Amandeep, for that very generous introduction. And thank you so far for all the attendees. And thank you to Sandra and everyone who's set this up. I see people are filling in person. We got quite a few participants now. So we'll get started. I'm going to present a little bit of framing for this. I think that these are just our objectives, which I think we'll address more later. And he said just some appetizers for the main course, which is going to be Yusuf and Joseph, two of our star residents, presenting some cases. And just to take a step back, I think it wasn't that long ago where glaucoma was really just a diagnosis. That's what would be referred, and there'd be kind of maybe one or two treatments, pilocarpine and trabeculectomy. And now glaucoma is a subspecialty, and we have all kinds of diagnoses. And depending on the diagnosis, we have different treatments. And I think the same is true for OCT. And I think even in the short time that I've been around, things have changed from kind of waving our hands at OCTs and glancing at them and maybe seeing a little bit of red, thinking that's glaucoma, and using it as an adjunct, to really becoming a science that we can approach these in a very formal and systematic way, and they become incredibly important for both the diagnosis and also for evaluating progression. So here's just an example of three nerves. And I'm going to say that one of these nerves has glaucoma, has glaucomatous optic neuropathy. The other two have red areas that we're seeing relative to the normative database. The Zeiss normative database, it is expanding now, but it has fewer than 300, 296 patients. And those patients were selected based on being quote unquote normal. So for instance, there weren't any high myopes in that database. And you can see a lot of red, and these are actual referrals that I received as potential glaucoma. So for the residents who have been in my clinic, they know that I'm very particular about using the term thin versus thinning. And also, if someone's going to tell me that the nerve is thin, or if there's thinning, I want to know what control they're using to define that. So let's talk about thin first. Thin traditionally has been relative to this normative database that I've already alluded to, and we're going to see some of the good and bad in our cases with this normative database. And the other good news in ophthalmology, we've all been using this across all subspecialties, is there's two eyes. And sometimes the best control for a patient can be their other eye. Thankfully, when the normative database fails, we have that other eye. Of course, that doesn't always work. We have patients with anisotropia. No surprise, when they have anisotropia, they have different nerves as well. They have different vessel distributions, and then they have different nerve distributions, because vessels and nerves are friends. They go together. Now, when we use the term thinning, we mean something specific. We mean that it used to be thicker, and now it's not. And that is going to be based on our progression analysis. And there's a few different ways to look at that. But I don't like to hear the term thinning when we see some red. Because it may or may not be, it may be an artifact. It may not be a glaucomatous optic neuropathy, but also For me, this is a very distinct and formal definition. And I said we have great progression software to help us achieve this. So these are our three controls, and I think it's very important. Again, not unlike in glaucoma, we've developed a language, PACG versus pseudo-X versus pigment dispersion. We have to do the same for our OCTs. So these printouts, I had to give a TED talk on OCT some time ago when we were doing the TED Talks in our department, and I showed this printout to the TED Talk trainer, and she said, "Well, you can't show that printout. It's too complicated. You need a story." And I agree that when you first look at this, it's complicated, but I think what I encourage the residents to do is you just have to get your reps in. And this becomes very much a pattern recognition. Not unlike a radiologist who looks at complicated scans over and over again, you can develop some pattern recognition. And I'm not going to go into details. I'm going to get Yusuf and Joseph to get into it, but I'm going to just say that if you're going to look at one aspect of this RNFL printout, it's this right here. Thankfully, the Zeiss printout puts it right in the middle. This is called the TSNIT plot. This is derived from the circular tomogram, which is this purple circle that you can see. I don't know if you guys can see my cursor or not. Can I get a...
Yeah, we can see that.
Okay, so I'm circling the circular tomogram. That is the area. It's 3.46 millimeters in diameter, where the machine tries to segment out the RNFL, which we know is most specific for glaucoma around the optic nerve, and it plots it on here. Plots it on this RNFL thickness plot, and we have both eyes. So here we can use our first two controls to determine if something is thin. We have the normative database, green being quote unquote normal from the 296 patients, and then we have both eyes. And we can see here, this is a little bit of an atypical nerve distribution. It's not surprising because if you look at the vessels on the deviation map, you can see that the insertion of those vessels is actually quite temporal. So temporal insertion of vessels, no surprise that the nerve is also going to be somewhat temporal. And that's what we see here on this circular tomogram. We see a lot of temporal nerve here. It's just not where all the other patients had their nerve. The most striking finding here is there's a large asymmetry between the right and left eye. So the right eye, if anything, is hypernormal in that area. It's actually in the white. And then the green, or the left is firmly in the green, but there's a huge difference between the two. So I think at first glance, we might say, well, there's an obvious discrepancy. These nerves look very similar. The rest of the nerve profile looks very similar. Yet there's, we're talking what, 60, 70 microns. We even think 5 or 10 microns is a difference. There's a huge difference. So yeah, at first glance, I would say this could be thin relative to the other eye. The trick is, and this is an unfortunate part about the Zeiss printout, and for those of you who do not use Zeiss, for instance, you can use something called the Hood report if you use the TopCon machine. The Hood report puts, you can see this green area down here, it puts the circular tomogram, the actual anatomy on center stage. And I wish we could do this in Zeiss. Unfortunately, it's been subordinated to the bottom right. This anatomy is crucial in interpreting our data to make sure that we've captured our RNFL properly. Look at the signal in this area. We don't care very much about the total signal ratio, but we do care about our signal in the area of the circular tomogram. You can see that it's very weak here, and this machine had troubles segmenting this area. So this is very important that we don't jump to any conclusions, and we repeat a scan like this and get a proper resolution in our superior temporal RNFL. And there's a pretty good chance that it's going to segment better and it's going to look like the other one. And that's where, so Donald Hood talks about being a radiologist first, and I've extended that to say if we want to be a stockbroker and look at green and reds, we have to be a radiology first and make sure we understand whether we have a good scan and whether it's been segmented properly. Now we get to that term of thinning. If you're going to look at one thinning pattern for all of glaucoma OCT, this is it. Joseph's going to present a case that's very similar to this from a diagnostic approach. What we see here is we see thinning in the infratemporal region. This is where the lamina cabrosa is most susceptible to glaucomatous damage. It's called the macular vulnerability zone. It's very common. We're going to go down to our TSNIT, and we're going to look at it. We have our two baseline scans, and you see this red area, which shows our most recent scan. There's this blunting of that inferior bundle. Okay, and I said this is the most common. The second most common is the superior bundle, and the slope is often in this fashion. If you see red in other areas first, I would look again, because these are the areas I said most susceptible to glaucomatous damage. And this is where we can finally use that word. There is true thinning on this patient, and we can use the stockbroker metrics, in this case, the inferior RNFL, and we can see red. And it's no surprise because there's obvious thinning. This patient's getting worse. This patient clearly needs an escalation in their therapy. So without further ado, unless we have specific questions on that, I will turn the time over to Joseph to start our cases.
Thank you so much, Dr. Schlenker, for the opportunity to present in these grand rounds. Let me share my screen here. Can you see my screen?
Yep, you're good.
Okay, so starting on with the first case here, we have a 72-year-old male presented for routine exam with his ophthalmologist that referred to our clinic as a pseudoexfoliation glaucoma suspect. Anterior segment exam showed pseudoexfoliation material on both eyes on the anterior lens capsule. Tmax was 21. He was phakic in both eyes. Visual acuity was 20/40 bilaterally. Intraocular pressure was 19 in the right eye and 21 in the left eye. So at a first glance, and the OCT RNFL looks of good quality with thin inferior temporal RNFL right here. The GCC shows a horizontal raphe sign in the right eye with thin GCC inferior temporally compared to the normative database, which is based on the people of the same age. So that is suspicious for glaucoma. Visual fields were reliable. The right eye shows a single central deficit, and the left eye shows scattered deficits centrally and more nasally. So the first question I have here for you, do you think this is glaucoma or no glaucoma, or you're really not sure? To answer this question, we'll dive deeper. So let's focus more closely at the data and analyze it like radiologists, as Dr. Schlenker said. You can appreciate that there is inferior temporal thin RNFL on the TSNIT plot and also present on the circular tomogram right here. Okay. And the GCC shows a true horizontal raphe sign with a thin GCC inferior and inferior temporally. These collective findings are concerning for glaucoma targeting the macular vulnerability zone. So to review the macular vulnerability zone, it was previously and first described by Hood et al. In 2012. And the most common affected bundle is the inferior temporal bundle, which result in central visual field defects. So from an anatomical perspective, it is important to review the different bundles of nerve fiber layer when discussing glaucoma. Bundle types are classified by their origin on the retina. So in A here, you can see an arcuate bundle arise outside the macula, about 18 degrees, or approximately 5.5 millimeters, along the superior and inferior temporal vascular arcades. In B, you can see the papillomacular bundle, which comprises of axonal fiber bundles projected from the macula, except those projected from the fovea. And it's about 5 degrees or approximately 1.5 millimeters. In C, you see the papillofoveal bundle, which contains axonal fibers projected from the fovea, and it's subsequently subdivided into two. One of them, D here, is the arcuate papillofoveal bundle, which comprises of axonal fiber bundles projected from the temporal fovea, arching over the foveola to the optic disc. And the second subclassification is the horizontal papillofoveal bundle, which comprises of axonal fibers bundles running largely parallel to each other from the nasal fovea to the optic disc. So back to our case, 2 years later, you can see the OCT here with thin RNFL, which was reproducible from the scan that was done a couple of years earlier. Same thing for GCC that shows inferior and inferior temporal thin GCC. When looking and repeating the visual fields here, you can see in the right eye, there are more central deficits compared to previous fields. However, on closer look, you can appreciate that these deficits are more pronounced better when we look closer. But in this follow-up, we performed a 24-2C visual field. And this type of visual field does more central point compared to a standard 24-2. And that's why these central deficits are more pronounced. To appreciate the difference between a 24-2C and a 24-2, on the left here, you can see a 24-2C where the central deficits are more pronounced. And on the right, you can see a simulated 24-2 field. And you can appreciate that there are fewer deficits. This actually highlights the importance of using different visual field testing for glaucoma patients.
So I just want to pause on this. Just want to go back there. So I just want everyone to reflect on the one on the right side of your screen. You're going through your clinic, you're seeing all kinds of patients. How many times do you see a visual field where there's maybe a few spots on your visual field?
That's every day, Matt.
Right? And there is this, I'm going to call it at this point a myth. There's a myth that glaucoma only affects the very peripheral vision first in an asymptomatic fashion. Okay? I'm telling you the most common defect is what Joseph just showed. Again, we want to imprint on our memory that it's actually extending into the macula, and we have this newer modality called the ganglion cell complex, where we're actually doing macular scans now on all patients. It's essential for a glaucoma workup now, and they often have a defect right in their macula. The problem is, how many points are in our macula on a 24-2 visual field? Well, depending on the definition, 4 to 6 points. And then as we know, there's false positives all the time in that area. And that's where that 24-2C, I agree with what, I saw Alan nodding his head too, and Amandeep. Many times someone's going to say, oh, next patient. I'll see this patient again in a year. I'll send them back to their optometrist. But if you see something in the macular vulnerability zone and you see something on the ganglion cell, I would say look harder. This one is quite obvious, at least because we got the 24-2C. And I think Joe's going to talk about what else we can do other than that, which of course is a 10-2 visual field. Many of these patients, if you probe them and get them to cover up one eye versus the other, they will be symptomatic from this. This is a paracentral defect. It is a real defect. So I think we have to kind of dispel this myth that glaucoma just affects us in a peripheral fashion, in an asymptomatic fashion, and it's a slow disease. For some patients on it's unfortunately much more aggressive.
Thank you, Dr. Schlenker. So to review the different options or visual field options that we can do for glaucoma patients, there are mainly 3 ones. The top here, you can see the 10-2 field, which is used often when there is a confirmed central vision loss or very advanced glaucoma. It concentrates 68 testing points into the central 10 degrees of vision with a tight 2-degree spacing. The downside of doing a 10-2, it doesn't provide any information about peripheral vision. So it cannot be like a standalone testing unless the peripheral vision is all gone. The second option is a 24-2, which is used as standard glaucoma testing. And it tests in a grid of 6 degrees apart. So the points are 6 degrees apart. And the testing extends 24 degrees temporally and 30 degrees nasally. Because it's the testing points are 6 degrees apart, it can miss small early defects in the central macular region, which actually we saw in our case. The third option is a 24-2C. And this option has the standard 24-2 testing points, but in addition, it has 10 additional central points within the central 10 degrees. So it's able to test more any macular deficits, which was very helpful in our case. So to summarize the anatomical and function change in our case, the patient had glaucoma primarily affecting the macular vulnerability zone, as you can see right here, with the image representing the bundle affected. And on the left here, on the right here, you can see the visual field pattern change, which was like paracentrally. So in summary—
Joseph, can we just go back to that?
Yeah.
So we promoted Tony, who's one of our star fellows, as a panelist. I want to ask Tony a quick question. So as I said, we have to use both of these now. We have to convince our technicians, not long ago, to not only look at the nerve, but also do a scan of the macula. Tony, for patients with early glaucoma damage, which do you think is more sensitive, the GCC or the RNFL?
I think that's a difficult question, Dr. Schwenger, but I would say typically we look at the RNFL first. They have to show some type of nerve fiber changes before they see some change in the ganglion cell. But I think it's hard. Sometimes you can see ganglion cell changes as well as RNFL changes afterwards.
Yeah, I think the bottom line is I've seen both. And then the other issue is sometimes, for instance, many of our retina patients, we can't get a good ganglion cell, which we're going to get to. And then sometimes we can't get a good RNFL. So sometimes we only have one option. But I've definitely seen both, where it's clearer on the RNFL in some patients, and other patients it's clearer on the GCC. So I wish I could say, we just, do one and find it there and then start moving to the other one, but it's unfortunately not that simple.
Thank you, Dr. Schlenker. So to summarize the case, the macular vulnerability zone classic defect with paracentral location, change can show up either on RNFL first, GCC first, or both of them. If no 24-2 visual field defect, we recommend that you consider doing a 10-2 or at least a 24-2C. So going on with case 2, this is a 71-year-old female with primary open-angle glaucoma referred by her ophthalmologist for uncontrolled intraocular pressure. Anterior segment exam was unremarkable. Angles are open, pseudophakic in both eyes with a Tmax of 24. Visual acuity was 20/30 bilaterally, and IOP was 12 in the right eye and 24 in the left eye on 3 classes, COSOPT and Lumigan. She was a high myope prior to cataract surgery. Looking at the OCT, you can appreciate that there is a lot of acquisition artifacts present in the right eye. However, before deciding that this scan is unreliable, we need to check whether the artifact is actually affecting analysis. This artifact is known as a Z-axis artifact. And a Z-axis artifact is an acquisition error that occurs along the depth dimension, most commonly occur due to in myopes, staphyloma, or focusing issues. So to visualize it more in terms of how this artifact works in an emmetrope eye, the machine is able to focus all the light on a single focal plane, and that's why the whole optic nerve will lie within the focal plane of the machine. However, in myopes or in the presence of staphyloma, because the axial length is longer in these patients, you can see here that part of the nerve is actually, the machine is focusing deeper, so it's missing part in the outer or like nasal area of the nerve. So you can see here, this is the box that represents the focal plane. And in myopes, or in cases of staphyloma, you can see here the rectangle where actually it's missing from the scan. And that's why we see those black acquisition artifacts. So when looking carefully in this scan, the Z-axis artifact or the black areas that are found here nasally are actually outside the region of the circular tomogram. So therefore, the inferior thin RNFL that we see on analysis is actually a true thin RNFL due to glaucoma. But when analyzing glaucoma data, we look at these printout that Dr. Schlenker showed earlier, and it is over time. So we need to pay attention to all scans. So here in the printout, there's data over 2 baseline visits, in addition to a follow-up visits with significant Z-axis artifact in the 2 baselines. So looking carefully and more closely in the left eye here, baseline 2, there is an area superior nasally that the circular tomogram analysis region runs over, and therefore it affects the analysis. And the machine actually interpreted this region at low RNFL thickness. So in cases like this, it is important to reestablish one of the baselines. So for example, in this particular case, the last follow-up or exam 3 right here should actually serve as baseline 2. So in summary, in cases like this, we need to check the quality of scan, including Z-axis artifacts when interpreting OCTs. However, not all artifacts will affect data analysis. So even the presence of artifact, we can actually perform some analysis on them if it's not affecting the circular tomogram, and repeat OCT scans and change baseline scans if needed to properly assess for change in glaucoma patients. Thank you all very much. And now I will give it over to Yusuf, who will present cases.
Actually, let's go back to your first one, showing the RNFL and the GCC. Wissam, I don't know if you can comment there. Sam is also one of our fellows.
Hi, Dr. Schenker. Good morning, everyone.
Can you go back to the actual printouts?
This one.
Here we go. Okay. So I think we have this knee-jerk reaction sometimes when a patient's a high myope. We almost turn off our brain. We say, oh, doesn't work. Nerves are funny. Printout's not good. Next patient, not useful for this patient. Wissam, we talked about the Z-axis artifact here, which is there, but not terrible, and really only affecting our acquisition and segmentation for one of the baselines, which can easily be addressed in glaucoma workplace. It can be reset. What do you think? Is this scan useless? Are we seeing some clear signs of a pathological glaucomatous process here? Advise us on what we can do with a scan like this.
Okay, so of course, with high myopic patients, there is a lot of problems in utilizing OCT, especially with RNFL thinning associated with myopia. But we can also here have some important information. Basically, we have comparison to the other eye, which is good comparison or good control here. So if we look at the left eye compared to the right eye, both are high myopic, but again, there is a difference here. There is more thinning in the left eye. Also, if we look at the GCC, there is the horizontal raphe line, which is pathognomonic to glaucomatous changes. So these are not completely useless. Of course, they are helpful. And also, they can be considered as a baseline for follow-up. And this is another control. So the same eye as baseline is a control for future follow-ups. So yeah, it's I still believe that OCT would be very helpful in myopic patients.
Great. Yeah, I agree. The other one is I want you to comment on the peripapillary atrophy here. Is this causing us a problem?
I don't think so. It's still I think it's helpful, Dr. Schlenker.
Yeah, so the answer is peripapillary atrophy sometimes is a problem because you have troubles identifying the disc. So then your circular tomogram actually gets shifted. And then the other issue is if the peripapillary atrophy is in our area of circular tomogram, well, you can't get good segmentation, basically. They made this diameter on purpose because usually this diameter misses the peripalpar artery. This is Joel Schumann, who's one of the inventors of the OCT. They actually took a lot of patients and they found that 3.46 millimeter diameter very rarely has PPA encroaching on it. And this patient's a good example. We can see the PPA most easily on the deviation map. I don't know, Joseph, if you can just show that right eye, the PPA on the deviation map.
Mm-hmm.
I think there's a bit of a lag.
Yeah.
He's probably getting to the deviation map. I'm circling it for myself, which is probably not helping anyone else.
Yeah. Oh, I think there is a bit of a lag. Sorry, Dr. Schenker. Let me just.
Yep, there we go. Okay, so now we see that he's showing the PPA. And then the other thing is, so there is a vulnerability zone defect superiorly there. So this is best seen on the deviation map. You see a red wedge. And then if you go to the one above it, the thickness map, you see a blue wedge. And I don't know, Joseph, you can highlight that blue wedge for us.
I'm losing my cursor here. Is it showing?
Yep, there we go.
Yeah.
So you're showing that blue wedge on the right eye on the thickness map superiorly. And if you look at Donald Hood, who kind of came up with a lot of this nomenclature, he would say that it's a vulnerability zone superiorly, not a macular vulnerability zone. Okay, because superiorly, it often doesn't go into the macula, which is actually fantastic for all of humankind, because then you don't get a paracentral inferior defect, which I think is more visually debilitating than a superior paracentral defect. But you can see for this unfortunate patient, they do have involvement of the ganglion cell area. So Joseph, on the right eye, can you show the horizontal raphe sign on the right eye? So here again, it's a myope, but we have great acquisition. We have great segmentation. And this patient has macular involvement in the right eye. And the bad news for this patient is they have macular involvement in both the superior and inferior on their left eye. So we see macular vulnerability zone defect inferiorly in the left eye, corresponding to a significant horizontal raphe sign. And it's almost like you get a little bit of a neural feel for that left eye. And it's just because they really do have a superior and an inferior defect, unfortunately.
Right.
And okay, good. So I don't know, does anyone have any questions or thoughts on this case?
Matt, quick question. How does the Z-axis artifact impact visit-to-visit progression analysis?
Yeah, Joseph, go to our kind of our traditional progression printout. We use this traditional printout less and less now because we have Glaucoma Workplace. So in this printout, for exam 3, December 13, 2023, that technician gets a medal, right? Because that technician unfortunately proved to all the other technicians that you can get this entire scan. You can get a full acquisition for this patient. The expectation has been raised now, right? So if a technician says they can't get it, I'll say, well, on December 13, 2023, someone got it. And for the baseline 2, you can see that there's black there, which means we're literally missing the picture. And Yusuf is going to talk about this. You can't segment something that's not there. And then what happens is kind of in the surrounding area, I think the machine needs context. So it couldn't segment well in the surrounding area. And that's why I think we have that artifactually elevated area superior to the black area. Because the machine's just getting its bearings. It's just trying to segment the area, and it's literally missing the picture beside it. So you often, if you have like a missing part, the segmentation part that is not good is often bigger than that and can actually be quite bad. So again, this is a technician issue. It's not easy, mostly for our high myopes, sometimes for some other. And it's just really important, particularly like I tell the technicians, if there's a lot of black away from the circular tomogram, no problem. Even if the signal strength is low, it doesn't matter to me that much. It's just when it encroaches in this circular tomogram, as it did in baseline 2.
Matt, what about if you have a floater?
Mm, I'm gonna suspend that question because I think we have an example of that coming up. Alan, we're on the same wavelength, cornea and glaucoma.
Well, we cause a lot of glaucoma for sure.
Actually, before we move on, there is a question relevant here. David Chen's asking, can I ask how much does dilation improve segmentation signal in high myopes?
Yeah, David, David's one of our new fellows. I think that's a good question. I think if the pupil's really small, it's a problem. But I think once it's a certain, size, I don't know the exact size, then it's really just making sure the technician gets the whole scan. Um, go back, Joseph, to our original RNFL printout, the one we spent a lot of time on. So if you look at the circular tomogram in the bottom left, again, the most important radiologic scan of this, which is subordinated to the bottom, you can see how it's cut off on the top. Okay. So the technicians just have to get the whole circular tomogram in that one image. And you can see it's just a little bit cut off there, and that's why there's a problem. But I agree, David. I think, lubrication probably helps, pupil size probably helps, and of course having the patient sit still.
Now, Matt, sorry, one more question. If we can go back to that GPA for a second. In that baseline two, in that circular tomogram, the artifact is just encroaching, I could even argue. Is that scan that bad? Because it's pretty common in practice.
Yeah, and that's where you really have to go to the TSNIT, which is the quarterback. So Joseph, if you can highlight, or you could go to your slide, which really highlights. So you can see baseline two. So the baseline two is the solid B2 there. If this was a complete image acquisition issue, that would be down to 0. Okay. And this is a huge problem for our average RNFLs. This is why we can't spend a lot of time with average RNFLs, because the second you have an image acquisition issue, your average RNFL goes down to 0 in that area. Or I'm sorry, the RNFL goes to 0, and that skews your average significantly. So this one, as Amandeep alluded to, it actually didn't go all the way down to 0 because it's kind of there. But it's low enough that it's going to make your stockbroker analysis going forward problematic, because it's literally half the thickness of the first baseline. So this clearly has to be eliminated. Now, the other good and bad news is this is kind of superior nasal, which is one of the places least likely to get glaucoma, at least early. So it's not a very important area. It's much more important if it's in the superior temporal or the inferior temporal area, because those are the areas we're most focused on.
Thank you.
All right, so we're just going to move on to next few cases here. So I'm Yusuf, I'm one of the PGY4s. Thanks, Joe, for presenting the first couple of cases. So case 3 is an 82-year-old female with mild open-angle glaucoma on the left eye. She's now pseudophakic, and she's here for a follow-up exam. On exam, her vision was 20/30 in both eyes with pressure of 16 on the right, 18 on the left on one class of glaucoma medication. And she had normal corneal thickness with open angles. So OCT RNFL and GCA were performed, and OCT was normal in the right eye. So let's focus on the left eye for this case. We can see from the thickness and the deviation maps, the OCT machine flagged the RNFL superior to the disc to be thin relative to the normative database. And this was also seen on the RNFL quadrant clock hour parameters, as the superior thickness was measured to be below 5% of the normal thickness. The GCC in the left eye also showed some possible thin supratemporal tissue, possibly in the configuration of a horizontal Raphe sign. Visual fields were performed and were relatively unremarkable, although they were not the most reliable. And on Glaucoma Workplace Viewer, we were able to check the guided progression analyses for the visual field and the OCT metrics. And we can see here in the left eye that the superior RNFL thickness appeared to drop from previous visits. And this made us question whether there was any possible progression. So in our heads, was there progression? Was there not? Were we unsure? We really had to look like radiologists and better answer this question by first looking at the OCT once more. And we first started by looking closely at the arcuate vessels as landmarks in the left eye. And you can see here that there's a discontinuity in the superior arcuate vessel. And we know that because the RNFL follows the vessels, this meant that there was also a discontinuity in the measured superior RNFL bundle. We can deduce that this occurred because the patient moved their eye vertically during the moment of the scan, and the motion caused the captured RNFL to be further away from where it should have been measured. And we know that RNFL is thickest closest to the nerve. Therefore, the eye movement led to a falsely interpreted thinner area of RNFL. And this motion coincided right through the RNFL tomogram and manifested as a decreased superior peak on the TSNIT plot. Now, another finding that didn't suggest true glaucomatous loss was the atypical pattern and distribution of the machine-detected loss. And you can see on the TSNIT GPA that there's a bit more thinning supranasal than we would expect in glaucoma, which is usually more supratemporal. And this raised some suspicions. And lastly, we can see here on the thickness map and where the arrows are, there was in the superior RNFL, it had somewhat of a stepped or ripple-like horizontal pattern of reduced thickness. And RNFL glaucomatous loss doesn't really occur this way. It's usually following an arcuate pattern along the path of the bundles, something similar to what we're seeing here on the right side of the screen. So did we think that there was ultimately progression? Probably not, but we decided to, bring them back in 3 months, repeat the testing, and just confirm our suspicions. At the follow-up 3 months later, we saw that the superior RNFL thickness was back and in the green. The thickness map showed a much more uniform superior RNFL bundle without any stepped or horizontal ripple-like pattern. And on the guided progression analysis, we can see that the RNFL was restored back to baseline levels from the previous drop at the last visit. And just to go over this once more to better illustrate this comparison, here's at the top, we see the pseudo-progression OCT caused by the motion artifact. And through the motion, and as you can see that the circular A scan is involved, from which we can deduce come from the discontinuity of the vessels. And this corresponded with a slightly reduced thickness on the RNFL tomogram and the corresponding diminished peak just superiorly there. At the later time, with a reliable scan, we can see good acquisition and a restored healthy superior peak with the tomogram showing a subtle increased RNFL from the previous scan that corresponded with the more reliable scan. So this case is really bringing
I just want to pause there for a sec. Thank you. Just go back to this.
Yeah.
So, we've talked a lot about the circular tomogram, and again, if we had the Hood report, this would be right in center stage. And this is an example where the circular tomogram, if you look at the segmentation, and I strongly encourage you to convince your technicians to put the segmentation lines on here. The segmentation lines are the red and the purple line that identify the RNFL. Okay, so if you don't have those on there, you don't really know what the machine identified. And I personally this is a personal preference. I like the black and white. I find when you put the colors on there, there's too much going on. Maybe that's just my brain. But if you look at these circular tomograms alone, in isolation, not taking into account the very clear motion artifact on the thickness map and the deviation map, it doesn't look that bad. I would say that the top circular tomogram actually looks like a fairly good segmentation. It segmented what was there. It's just what was there, as Yusuf alluded to, was not the RNFL in the same one that has been compared to in the previous ones. And this also just speaks to using the TSNIT plot, which Yusuf has put in the middle here as our console. My 10-year-old son would call this the cheat code. The cheat code is the TSNIT plot. Okay. And then once you see that there's a problem on the TSNIT plot, then you go looking. And that's where you go and look, and there's clearly a motion artifact. I mean, the vessels, we know vessels don't look like that. There's no gaps in vessels. It's quite obvious that there's something wrong there. But it's just important to see first on the TSNIT, and I think this one really illustrates what a profound difference a very small, I'm sure there's a very subtle eye movement. And yeah, obviously this scan should have been repeated right away. That's way too much motion artifact going through our circular tomogram.
Awesome. Thanks.
And then, sorry, one more. I was going to ask Taylor. I don't know if Taylor's still with us as a panelist. We all know Taylor. been a fellow with us, was a resident with us. Taylor, are you able to answer?
Yeah, I'm here.
Okay, so let's go to the your very first slide showing the decrease. Yeah, so right here. Sorry. Okay, so Taylor, what we did not show here, I'm sure you know why, we did not show the average RNFL thickness. We only showed the average inferior, which is on the top, and the average superior, which Yusuf has flagged as potentially lower. What if we would have looked at the average, what do you think it would have shown? And is there ever a time where we care nowadays about the average RNFL thickness?
Um, you may the average probably would have shown maybe a slight decrease, maybe a couple points, but or it could be very similar to the previous average. So it wouldn't have picked this up. It would be sort of lost in the wash. And I never look at average RFL anymore. I only look at the average inferior and superior, and then look at the TSNIT plot and as you've gone over the circuit tomogram, everything else. And I actually like looking at the heat map the most. And what actually I found more interesting about this scan, if we can go to the next slide and actually show the two scans that are keep going. If you look at there's actually two sort of areas that are concerning on the scan. It's the one that we've identified here, but if you look at the inferior RNFL and you look at how the poor scan is, the hump there is more peaked and has more steep edges than the one below it. So that was actually a little bit, I was looking at that and thought that was concerning as well, but it's probably because of the segmentation of the minor motion artifact as well. So anyways, something that I thought everyone should know, because sometimes you can see with the peak or the steepness of a hump on the RFL, that can be a sign of early glaucoma as well.
For sure. Yeah, so thank you. So I think Taylor summarized it well, and Tony just put it in the chat too. We no longer, I don't think there's any good reason to look at average RNFL anymore. It's just washing out potential. It's just going to take you longer to find something. There's either a problem in the superior, or there's a problem in the inferior, or there's a problem in both. And if you just look at the average, it's like looking at the average temperature between Costa Rica and Toronto. You never really care about the average between the two. It's just not really relevant to anything.
All right, thanks, Taylor and Dr. Schlenker. So this case, we'll just kind of move on here. So this case brings up a discussion on artifacts on OCT, RNFL, and GCA, and it's a good discussion segue. So artifacts can be broadly grouped into segmentation artifacts and acquisition artifacts, and these are two distinct entities. But it is important to know that acquisition artifact will also always result in a segmentation artifact, but it's not necessarily true the other way around. So segmentation artifacts occur in the setting of comorbid conditions, often when the OCT can't identify and segment the layers in question, and this leads to an erroneous perceived thickness of the tissue. Causes of segmentation error include changes to the nerve. For example, peripapillary atrophy can occur in vitreopapillary traction and other causes. Also changes to the macula like VMT, ERM, and pigment epithelial detachment. And also cases of atypical anatomy and pathological anatomy, which make it difficult for the OCT to segment. Acquisition artifacts occur when the OCT can't grossly capture the retinal tissue, and this results in an inadequate segmentation of the retinal layers, as we previously discussed. Acquisition errors will lead to a below floor measurement typically, and are often represented as black areas in the thickness map, which you can see here on the scan, and what Joseph presented with a Z-axis case. Causes can include low signal strength, blinking, motion, which occurred in the previous case, and other types of acquisition artifacts are mirror artifacts when the OCT is out of range, decentered, the dirty lens on the OCT, and then ocular causes such as floaters, media opacity, and cataract. So to summarize, this was a case of pseudoprogression due to motion artifact, which is a type of acquisition error. And artifacts can be grouped into acquisition and segmentation artifacts, with acquisition error always leading to segmentation error, but not necessarily the other way around. And it's always important to evaluate the quality of the scan prior to interpretation. So case 4 is a 27-year-old man with a family history of glaucoma in his mother, and he was referred as an open-angle glaucoma suspect. On his exam, his vision was normal, and his manifest refraction was -5 diopters in both eyes. His pressure was 10 in the right, 11 in the left, without the use of glaucoma medications. So OCT, RNFL, and GCA were performed and are shown here. And looking at the tomogram first, there was good segmentation of the RNFL and the acquisition appeared normal. There was a symmetric, relative thin superior RNFL in both eyes, which can be seen here on the deviation map. And this is corroborated on the TSNIT plot, as well as the superior quadrant of the RNFL pie chart. The GCC appeared normal, and visual fields were unremarkable. So we can question ourselves, what was the diagnosis in this case? Was it open angle glaucoma, normal tension? The pressure was normal, the visual fields were normal. So was this pre-parametric, or is this something else? And to answer that question, we had to dig a bit deeper and put our radiologist hat on to figure this out. So just looking at the OCT once more in the RNFL, in this case, the machine has detected an area of thin RNFL relative to the normative database. And we can see this area just superior to the nerve, and it manifests as red on the deviation map. We can also see here a trough in the TSNIT plot in both eyes corresponding to this area of RNFL. But is this really glaucoma? And when we analyze the OCT RNFL, we first need to look at the vessels. And we know that, as we previously spoke about, vessels and nerve travel together. We can see a very wide distribution of the vessels here on the OCT. And atypical vasculature will likely mean atypical RNFL. So this is what we are thinking here. There's a very wide vessel distribution, which means that the superior RNFL has actually been split into 2 bundles, something called the split bundle configuration. And this splitting has left that thickness void in the middle, which is interpreted as RNFL loss. On the TSNIT plot, we can actually see here that there are 2 healthy peaks superiorly, representing the split bundle, one coming from the supratemporal area and one coming from the supranasal area. And these peaks are almost hypernormal. In fact, that supranasal peak is almost in the white compared to the normative database. Additional features we thought didn't really fit glaucoma included the normal GCA and visual field, the highly symmetric nature of the findings, and the non-characteristic location of the quote-unquote RNFL loss, which was a bit more nasal than what we expect. So what did this patient have? They had a split bundle RNFL configuration, and this was not glaucoma. And to summarize this case, this split bundle can mimic glaucoma. It can occur in small, large, or tilted myopic nerves. It's often symmetric and will demonstrate a wide vessel distribution. That's the key here. You'll often see a double hump RNFL peak that may or may not correspond with the normative database. And when we look at the other tests, there's typically, if there's no glaucoma, we won't be seeing any typical glaucoma findings on the GCC in the visual field, similar to what we saw in our case. So this case was really an example of red disease, and we'll go into a discussion on red disease and having an approach for these cases. And red disease is the term for when indices on the OCT fall outside the normal statistical limits derived from the normative database, and these indices are then flagged with the color red. The goal here is to differentiate true nerve loss from atypical anatomy, and there is a bit of overlap here, so sometimes it can get a bit muddy, but these are the 2 broad classifications of red disease, and this can be further complicated by segmentation and acquisition issues, which you have previously discussed in this talk. So, of course, when we see red, we're looking for true glaucoma, and this is often the first suspicion because we don't want to miss anything sinister. Here, in this case, the OCTs showing some pretty obvious glaucomatous findings with macular vulnerability zone defects involving the RNFL and the GCA, and we can see all over this OCT red, which is in keeping with glaucoma. And we first obviously established good segmentation and acquisition, but this was a true nerve loss case. And in contrast, we can get red around the optic nerve that is just simply due to atypical anatomy. And this was a case that we just previously went over, the split bundle RNFL. And just to reiterate the points, the split RNFL left a void superior to the nerve, but looking closer, we saw 2 healthy peaks in the distribution of thin RNFL that was not really in keeping with glaucoma. And when we have an acquisition issue, the RNFL is unable to be segmented, and we always get red disease. So Dr. Slomovic, this answers your question over here. Over here in the thickness map, we can see a black area that has been caused by a Weiss ring, and that's preventing the OCT from sensing the retina. And on the deviation map, this shows a corresponding area of thin RNFL, which is overlying the tomogram area, which is where we take our reading for the TSNIT plot. And this has caused the RNFL to go all the way down to 0 past the floor because we had no acquisition. And it's important to look for reasons of abnormally thin RNFL to explain why the machine is showing red, for example, in this case, poor acquisition. And the last component of red disease is, sometimes there's good acquisition, but the segmentation is not correct. And here, this has occurred because of an epiretinal membrane. The GCA thickness isn't detected adequately, and this results in abnormally perceived thin tissue. ERM-induced segmentation errors often have a propeller-like GCA defect, and we know that glaucoma doesn't really behave this way, so we can attribute the red to be from poor segmentation. So just to summarize red disease on OCT can be due to true RNFL loss, but can also be due to atypical anatomy from segmentation issues due to comorbid conditions or acquisition issues. Having a good approach to when we see red on OCT starts with assessing the acquisition and the segmentation of the scan, and if it's appropriate, evaluating the distribution of the possible tissue loss can help determine whether there's true glaucoma or just abnormal anatomy. And of course, you can always look at the corroborating test to see if there's cross-structure or structure-function concordance. So we'll briefly go over our last case. I know we're getting close on time here. Case 5 is a 57-year-old female referred for elevated IOP. The Tmax was 23 in the right, 20 in the left, and she had a family history of glaucoma in the mother. Visual acuity was normal. The pressure was slightly elevated in the right eye at 22 with normal corneal thickness and open angles to TM. Starting off, we had good segmentation and acquisition, and really looking at our stockbroker metrics, we didn't really see much here. Everything's in the green. The key parameters are green. The TSNIT is all in the green. The clock hours are in the green, and this is also seen on the GCA. Visual fields showed some depressed points supranasally, but the mean deviation was not especially impressive, minus 0.59 decibels. So let's review this case and take a bit of a deeper look. The key parameters, as you mentioned, were all in the green. So can there really be anything wrong here? As we have said many times in this talk, and Dr. Schlenker really likes to stress this, we need to get back to looking at the scans like a radiologist to find out the answer. So looking closer at the TSNIT plot, so there's actually some asymmetry between the left and the right eye. And while still within the green, the inferior RNFL bundle does show to be reduced in the right eye compared to the left eye. And this is talking once again about one of our controls being the other eye. There may be some early, not captured in the RNFL tomogram, some thin RNFL in the supratemporal peripapillary region in both eyes. And we know that this is a location that's suspicious for possible macular vulnerability zone defects. And the clincher really comes from looking at the concordant tests, which shows an infratemporal horizontal raphe sign and a superior arcuate defect on the visual field. So this patient actually did have glaucoma when really all we saw was green on the OCT. And we call this green disease. This case is a good example of it. And green disease is when there's true nerve loss in the OCT without any obvious red flag parameters. And green disease may occur when the tissue is thick relative to the controls derived from the normative database, or when the tissue is artificially thick. So in the first scenario, green disease can occur when the tissue's thicker than the normative controls, and this is a consequence of the functions of the limitations of the normative database. And you can see this is what happened in the previous case. The key parameters are all in the green, but we can see some glaucomatous loss clearly occurring. And then in the other hand, green disease can occur when there's secondary artificial elevation of the RNFL. This can be due to several different causes, segmentation error, swelling, or disc edema and traction. And here you can see here, there's a case where the key parameters are all in the green, but the nerve is swollen. And on the deviation map, you can actually see here, there's some thin relative RNFL tissue infratemporally, but the swelling is masking the true extent of the glaucomatous damage, which would actually be more prevalent if the disc was not swollen. So we need to look at like radiologists in this case, and often looking at the GCA in the visual field can confirm our suspicions. So this is our last slide here. As a reminder, when we see green across the OCT parameters in the TSNIT plot, it doesn't necessarily mean that there's no glaucoma. And it's important to remember the three controls, especially looking at the other eye in previous tests or future tests. The normative database isn't always going to be helpful in these cases. Context is key. It's important to look for reasons why there could be artificially elevated RNFL masking true glaucoma, the true glaucomatous damage. And then it's important to corroborate with other tests like the RNFL, the GCA, and the visual field to confirm suspicions. So here are our learning points. We'll just leave them up here. This brings us to an end of grand rounds. We'll just quickly read over them. Glaucoma commonly affects the superior and inferior poles and can progress to cause central vision loss, especially involving the macular vulnerability zone. OCT can be thin relative to the normative database or the other eye, and thinning is used exclusively in the setting of progression. Remember the three controls during OCT assessment. OCT artifacts need to be identified and data must be interpreted accordingly. Red disease classification involves atypical anatomy and or true nerve loss and can overlap with acquisition and segmentation issues. And lastly, glaucoma can manifest as green disease, so think like a radiologist. Be sure to check out OCT cases. Many of these cases are on the site, and we welcome case submissions for those interested in showcasing unique presentations of glaucoma, retina, and other pathology.
So question for you, or Yusuf or Matt, that last case, the green disease, is quite interesting because, you know, we've often heard that you need to have 20, 25, even 50% RNFL loss before visual field defects. And this kind of goes counter to that, even if the patient's starting with, you know, a supranormal thickness. Any thoughts on that paradigm?
So I guess in this case, it's really just a function of the normative database. So this patient just had thicker tissue than other patients, and you know it's tough to tell exactly how much percentage of RNFL tissue they lost. But if we were to take this scan several years prior when there was no glaucoma, we'd probably see a much thicker RNFL tissue. And yes, there is a superior arcuate defect here. So it's pretty clear that there is glaucoma. Mm-hmm. And I guess to summarize and answer your question, we don't know exactly what percentage of tissue was lost, but the fact that there is something here on the deviation map, that's not the perfect picture. It's a little bit outside of the tomogram, but it wouldn't surprise to say that there is a substantial amount of tissue loss. This patient just had thicker tissue to begin with.
Thank you. Matt, there's a question for you here from Dr. Gray. Where did it go? What OCT numerical values, if any, are you documenting in your patient chart?
Yeah, Dale, that's a great question. Yusuf, do you want to go back to the Weiss ring example?
Sure.
And this is where I said I like to call these the stockbroker metrics. And I do get referrals sometimes where people tell me the average RNFL. So they tell me the average temperature between Costa Rica and Toronto over time. And I think sometimes it can be useful. Again, it's not as sensitive as looking at the inferior and superior. But if you have great acquisition and great segmentation over time, you will eventually show that there's a decrease. But the problem is if you have one little problem on your scan, you can see here the RNFL went down to 0. And we know what an RNFL of 0 goes. Like this is we know there's a floor of like 50. There's like neurosupportive tissue that goes up to 50 or 60 microns in the RNFL. This goes down to 0, and it's going to significantly affect your average RNFL. It's going to bring it, 5 or 10 points down. which is enough to make it look like there's a problem. So I spend very little time documenting absolute numerical values. I feel like they always need to be looked at in the context of the scans, and that's why I'd rather always be going back to our progression scans or glaucoma workplace to be looking at the numbers in the context of the scans.
Thanks, Matt. Another question for you is why haven't the manufacturers increased those databases? Because I think we've heard some of the limitations of it, but it seems like there's an opportunity there.
Yeah, it's a good question. They actually are in fairness to them. But I know it's like you could get like Kensington in one day does how many OCTs? I mean, to think that we only rely on 296 patients, or we have for years, since whenever 2009 or 2012 when people started using this, it really is a shame, and I think it's on us a bit as clinicians to demand it and to expect it, because it's at the end of the day, it's a business, and if we're happy with what they're providing, then there's not a lot of motivation to change anything.
Right.
Matt, fabulous rounds, really very practical and great presentations by the residents. Quick question. I mean, when you're in a busy clinic and you've got all this data to evaluate, it's hard to do. When is AI going to sort of come into play here? I mean, this seems like a natural for AI, deep learning, so we can, press a button, just say, yeah, the patient's got progression.
Yeah, it's also a good question, and I do get that feedback sometimes. It's like, Matt, we can't look at everything, and I agree that we have some limitations. Though I will also say the PGY3 residents, when they come through with us for 2 months, they go from, I said, kind of glancing at this to really me walking in the room and pointing. This is a macular vulnerability zone defect. I also see it on the GCC. It's manifesting a little bit in the visual field. We need a 10-2 visual field. In 2 months, they get it. Most of them get it. I've been impressed. Of course, they're working hard. So I think it's doable. Can it get better with AI? Well, sure it can. I think that there's two areas, and I'm more excited about the first one, which is really enhancing the quality of our scans. The black box, like, is it progression? Yes or no? Well, I'm worried it's going to be garbage in and garbage out, not unlike what we have to deal with now. So I think for me, the first step is really getting better resolution and hopefully using better segmentation algorithms, which could be AI enhanced, for instance, to really make sure in the most granular detail possible that we have the tissue. Because once we have the tissue, I don't think you need AI. I mean, you can look at a graph over time. Once you have it, I actually don't want. So if you go to glaucoma workplace, there's actually there is what you just asked for. You can say progression, yes or no, progression, yes or no. There's like a check mark. And I think it's largely useless so far. It's probably misleading people. It's leading to a lot of false positives, leading to a lot of anxiety in patients. So I don't know if we're there yet, but surely it's only going to get better. I think it's already a science, but it's going to become a better science.
Mm-hmm. Great rounds.
Thanks, Matt. Last question, and this may be simple, but is that database unique to each manufacturer? So, because I'm familiar only with the Zeiss printout, but you're nodding yes.
Yeah, they all have about 300, and
Okay.
it is a rigorous process. Because I've asked them, the question you just asked me many times, like, come on, can't you just come to my clinic, like come to Toronto Western and just like
Yeah.
get a database, like what? And they go through this rigorous process, and they have to do it through the approval, like the regulatory bodies as well, to say like this is our database, this is how we constructed it, these are the type of patients, this is our
Right.
rationale. So in fairness to them, it's a little bit, but yeah, to think that I mean, even now, so if you change your baseline right now in glaucoma workplace, it takes a long time to process, and I'm just
Mhm.
hoping eventually we'll be able to just process more data much quicker, bigger narrative databases, more scans on patients, maybe at home someday, just getting so much data. So it's only going in the right direction, I think.
Good. Thank you. Getting lots of positive feedback on the rounds. Congratulations, Matt, Yusuf, and Joseph. Great job this morning. Thank you for that. And we'll close it out now. Thank you.
Thank you so much.
Have a good day, everyone.
Great rounds.